Muted.
Good afternoon. This is Nick Weislogle with the Health Policy Institute of Ohio. Thanks for joining us for HPIO's webinar on private health insurance. Please note that to reduce any background noise, your audio has been muted. Slides from today's webinar will be posted on HPIO's website later this afternoon. We're also recording the webinar today, and we'll be posting that recording to our website soon. To start the webinar, Reem Ali, HPIO's Vice President for Healthcare System and Innovation Policy, will provide an overview of our Private Health Insurance Basics publication. Later on, we'll have a panel of speakers discussing private health insurance in Ohio. If you have any questions at any time throughout the webinar, please feel free to type them into the chat box tool, and we'll answer them as soon as we can. And now here's Reem.
Thank you, Nick. Good afternoon, everyone, and thank you all for joining us today. For those of you who are unfamiliar with HPIO, I just wanted to give you all a bit of background information. We are a small, nonpartisan, statewide organization, and our vision is to influence the improvement of health and well-being for all Ohioans. And our mission is to provide the independent and nonpartisan analysis needed to create evidence-informed state health policy. We also want to thank our core funders listed here for their continuing support of our work. On this webinar, we will begin with an overview of HPIO's publication, Private Health Insurance Basics 2016. I want to thank Zach Reed and Haley Aka from HPIO, as well as Doug Anderson from Bailey Cavalieri for their contributions to this publication. After an overview of the Basics publication, we will move into a panel discussion on current policy issues and trends impacting the private health insurance market. And we'll be joined by Marie Curry with Community Legal Aid, Patty Starr from the Health Action Council, and Dr. Craig Teely from Caresource. At the end of both the Basics presentation and panel discussion, as Nick mentioned, you will have the opportunity to type in your questions into the chat box. We will answer all your questions as time permits. We are looking forward to your engagement throughout the webinar. HPIO released its Private Health Insurance Basics publication just last month in October. The purpose of the publication is to provide basic foundational facts and information about private health insurance to inform the work of state policymakers and other health stakeholders around the state. The publication is divided into a series of 6 fact sheets and a glossary resource that provides definitions for common health insurance terms. HPIO also put together a 1-page overview sheet to provide you with a summary of information included in each of the 6 basic fact sheets. On this webinar, I will be highlighting data from the fact sheets, and it'll also help to provide some context for our panel discussion. Again, a reminder to type your questions into the chat box throughout the webinar. Fact sheet 1, you see on your screen, provides an overview of private health insurance coverage. This fact sheet discusses the purpose of health insurance and how it works, and also provides information on Ohio's coverage landscape and what it means to be uninsured. In 2015, more than half of Ohioans, around 57%, received coverage through private health insurance. Around 37% received coverage through public health insurance. When we talk about private health insurance, we are not including federal, state, or locally funded government programs such as Medicare, Medicaid, and military or veteran coverage. Those are federal or state-funded programs that fall into the public health insurance category. And when we talk about private health insurance, it does include 3 market segments. And those market segments are non-group, or individual and family coverage, as well as small group coverage and large group coverage. The small and large group market segments are generally referred to as employer-sponsored health insurance coverage. From 2013 to 2015, the private health insurance coverage landscape which includes employer-sponsored health insurance coverage and the individual family coverage, those two rows on the bar graph at the bottom. They did remain relatively stable over that time period, increasing by only about 2 percentage points. It's important to note that during that same time period, the uninsured rate in Ohio decreased by half, falling from 1.4 million to 681,400 Ohioans. This sharp decline in the uninsured rate is largely attributed to Medicaid eligibility extension in Ohio, which did take effect in 2014. The ACA was designed to reduce the percent of people who are uninsured through the extension of Medicaid eligibility and the availability of subsidized coverage for certain individuals through the ACA health insurance marketplaces. However, the ACA was not designed to provide universal health insurance coverage and does not extend federally funded or subsidized coverage to certain groups such as undocumented immigrants. Now, some of the top reasons people remain uninsured include the high cost of health insurance coverage and being unable to receive subsidized or public health insurance coverage. Those who remain uninsured experience a number of barriers to receiving health care when compared to those who are insured. And you can see the graphic on your screen that shows that 52% of uninsured people did not have a usual source of care compared to only 12% of those with private health insurance. 27% of uninsured individuals went without needed care due to cost compared to 5% of those with private health insurance. Now this shows the data at the national or U.S. level, but in Ohio we can see similar trends where uninsured have greater trouble accessing coverage than those who are insured, particularly those with private health insurance. Factsheet 2 covers private health insurance regulation. In this fact sheet, we provide information on state regulatory functions, the consumer appeals process for health plan issuer decisions, and federal laws and regulations. I'm not going to spend too much time on this fact sheet, but do encourage you to go to our website and take a look at this fact sheet if you're interested in this information. Fact sheet 3 provides a summary of Affordable Care Act reforms impacting the private health insurance market. This includes reforms around obtaining and maintaining coverage, premium rate setting, covered services, and cost sharing, as well as consumer protection. This fact sheet provides a summary of each reform and also outlines the different market segments impacted in the private health insurance market. So for example, small group versus large group coverage and individual, family, or non-group coverage. The fact sheet also identifies whether ACA reforms impact grandfathered health plans, and those were in effect at the time the ACA was passed, so they were individuals who were enrolled in the health plan prior to enactment of the ACA, and these grandfathered health plans are exempt from any of the ACA reforms. Again, I'm not going to spend too much time on fact sheet 3. It is a really good resource and table for those that would like to have an overview of the different reforms impacting the private health insurance market. So again, I encourage you to go onto our website if you're interested in this information and download this fact sheet. Landscape, individual mandate, as well as the ACA health insurance marketplace data and trends. When we take a look at the non-group coverage, which includes the ACA health insurance marketplace, you'll see that non-group coverage only accounted for less than 6% of insured Ohioans in 2015. The number of Ohioans with non-group coverage did increase by 2 percentage points from 2013 to 2015, primarily due to Ohioans gaining coverage through the ACA health insurance marketplace. Under the ACA, states are required to establish health insurance marketplaces or exchanges that enable eligible consumers and small businesses to compare, select, and enroll in private health insurance plans. Ohio as many of you know, has a federally facilitated marketplace, but retains approval authority over plan management activities. Under this particular arrangement, our Department of Insurance oversees the certification of qualified health plans and approval of coverage documents and premium rates. As of 2017, there were 28 federally facilitated marketplace states and an additional 6 federal and state partnership marketplace states. In 2016, nearly 244,000 Ohioans selected plans on the marketplace, which is a 4% increase when compared to 2015 enrollment. As of about the end of March of 2016, around 212,000 Ohioans, or 87%, had effectuated their coverage by paying their first month's premium. According to the Kaiser Family Foundation, 30% of Ohioans potentially eligible for marketplace coverage in 2016 had effectuated their coverage. This places Ohio in the bottom quartile of states for marketplace enrollment as compared to other federally facilitated marketplace states. Of those Ohioans with effectuated coverage, around 82% received advanced premium tax credits, and another 45% also received cost-sharing subsidies. Ohio has the 5th highest bronze plan enrollment and the 5th lowest silver plan enrollment among FFM states. This means that Ohioans are selecting plans with lower premiums, but these plans also tend to have higher out-of-pocket costs. Factsheet 5 in Health Insurance Basics covers employer-sponsored health insurance. And in this fact sheet, we provide information on the difference between fully insured versus self-insured coverage, as well as employer-sponsored health insurance trends, employer mandate, and some information on the Cadillac tax. In 2015, a majority of Ohioans, approximately 6 million or 52%, had ESI coverage. It's important to note that this is more than 90% of people with private health insurance coverage in Ohio as of 2015. The percentage of Ohioans with ESI coverage has remained relatively stable over the past few years as well. We have seen a long-term trend in a decline in ESI coverage, but again, that's been over a longer period of time that you can't see from this graphic. Large employers are more likely to offer employer-sponsored health insurance than small employers, who often cite high costs as the primary reason for not offering coverage. In 2015, only about 32% of companies in Ohio with fewer than 50 employees offered health coverage compared to nearly 97% of companies with 50 or more employees. In total, around 51% of companies in Ohio offered health insurance compared to the U.S. average of only 46% in 2015. In Ohio, the percent of workers offered employer-sponsored health insurance coverage increases with income levels. So you'll see from this graphic that nearly 87% of workers with incomes above 400% of the federal poverty level were offered ESI coverage in 2014, compared to only about 28% of workers with incomes below 138% of the federal poverty level. To put this in perspective, 138 of the federal poverty level amounts to approximately $28,000 for a family of 3 in 2016. I also want to note that these are only the percent offered employer-sponsored health insurance coverage. So when we talk about actual uptake, these percentages are likely to be smaller. Employer-sponsored health insurance operates very greatly by a worker's full-time or part-time status. I'm going to share some information that is not on the slide, but in the U.S., only 21% of part-time workers who worked less than 30 hours a week were offered employer-sponsored health insurance coverage, compared to 72% of full-time workers, those working 30 or more hours a week in 2014. And then move along to our last fact sheet, which provides an overview of policy issues impacting the private health insurance market. In this fact sheet, we provide information on high deductible health plans, paying for value, network adequacy and transparency, the ACA risk program, so some discussion of the reinsurance, risk corridor, and risk adjustment programs, as well as information on the trend around mergers and consolidations in the healthcare market. One of the issues highlighted in this fact sheet is the increase in high deductible health plans that we see. From 2012 to 2015, Ohioans have seen a steady increase in HP enrollees, so high deductible health plan enrollees, with a bigger jump from 2013 to 2014 that can largely be attributed to the establishment of the Affordable Care Act health insurance marketplace. We will get into a deeper discussion of the policy issues and trends that we're seeing in the private health insurance market with our panelist discussions. In addition to all 6 fact sheets, we also created a glossary that includes common health insurance terms and definitions, which we also encourage you to use as a resource and guide throughout your work. And with that, I'll take any questions that you may have. Feel free to type questions that you have throughout the chat box, and we'll type if there were other questions we'll also ask questions that were already typed in the chat box if there are any. All right, no questions on this information? Okay, we will move on to our panelist discussion, and we can, of course, circle back to some of the information shared during the panel discussion as well. And I'm going to introduce our panelists. So we have Patty Starr with the Health Action Council, Dr. Craig Seeley with Caresource, and Marie Curry with Community Legal Aid. I'm going to go ahead and unmute Patty. Each panelist will give some brief opening remarks, and then we will have some questions to ask of the panelists. And then, of course, you all are welcome to enter questions into the chat box as well. Right, Patty?
Hi, Reen. It's Patty.
Go ahead, Patty.
Great, thank you. Thank you for having me today, and thank everyone else for joining us. I'm going to talk a little bit about some of the trends that we're starting to see for 2017 around employer-sponsored health insurance coverage. Some of the things that we're starting to see is a continued use and movement to the high deductible health plans. In addition to that, we're seeing a continued increase in employee cost share from higher deductibles, higher co-pays, increased dollar amounts for out-of-pocket cost sharing if someone's going out of network. And then also we're still seeing an increase in premium cost sharing with employees. Some employers are taking different philosophies regarding the premium cost sharing specifically. They may be passing on the annual increase going forward and sort of capped it. And traditionally, it's relevant to the employer size. Others are splitting that annual cost increase differently, and the employer may be picking up a smaller portion going forward, or now they may be looking at a 50-50 split of the increases on an annual basis as well. So just different cost sharing models as we go forward. We're also seeing employers taking a different philosophy as well as disruption goes to their employees around the healthcare benefits. There was a little bit more of a conservative attitude that they may not want to cause a lot of disruption, but they're actually starting to now review new disease management type programming for those who have chronic conditions. They're looking at narrow networks. From a narrow network perspective, today most of the plans that employers are offering in the larger group market probably have about 90% of all providers in a given region, and some of these employers are now starting to look at narrow networks that would go down to maybe even as low as 50% of providers in a given region. That decision is not 100% cost-based anymore. Some of it's cost as well as quality and transparency measurements in that decision making. They realize that they may have to pay a little bit more on the front end sometimes in order to save costs on the back end. They're also looking at centers of excellence. Traditionally, when you think of centers of excellence, we've thought about more on a national basis. There may be one hospital or two hospitals that are identified for, say, heart issues. Now that's also being defined on a regional basis as well. So if you have 4 or 5 hospitals competing for the same type of business, one may be elected to do heart or transplants or knee replacements. So it's being done both on a national and on a local basis, that designation. Employers are starting to incorporate employee advocacy programs as well. They feel that a lot of money is going into offering benefits to employees to ensure that they have access to good quality of care, but not everybody actually knows how to access that care. So there's more emphasis being put on how do you use that coverage, how to create a seamless process when you are accessing the care. So employers are starting to invest in some of the employee advocacy programming that's available as well. And sometimes it's available through an insurer, and sometimes that's offered by a separate entity. Another item that we're starting to see happen is there's increased promotion and purchase independent and from insurance companies as well as within insurance companies, targeted messages for individuals with chronic medical conditions, trying to keep them in the system, trying to get them appropriate care at the right time, right place, right cost, trying to eliminate some of the additional complications that come along. So instead of doing mass targets, instead of doing mass marketing and mass messaging for some of these items, they're actually starting to do more targeted messages as they move forward. In addition, the cost transparency tools, most of the insurers are now offering that as part of their program if you log on to their website. So it could be specific to that employer and that employee when they log on. If that's not a total benefit to the employers, they're also purchasing external services that provide those cost transparency tools as well. From a pharmacy benefits management perspective, we're starting to see increases in copay amounts. There's also an expansion of the tiering of the benefits going forward. So some plans only may have had 2 tiers in their pharmacy program. So you might have had a generic, and then you might have had a brand name tiering system. A lot of people have added and they continue to add specialty. We have seen some employers implement as many as 7 different tiers in copays on the pharmacy. Not super popular yet, but we're keeping track of it. Obviously, there's a new increase in a lot more attention actually being provided to specialty drug costs as we go forward. That the trend on specialty drug costs continue to increase and is expected to continue to increase for the next several years. So there's more management being done on those types of medications and more discussions, even some new internal rules and regulations on how they disperse and distribute those types of medications. So if it's a specialty medication, we're seeing that maybe a 30-day supply is actually not going to be issued. Employers are starting to ask that the initial prescription be issued possibly at a 10 or 15-day supply, because some of those medications, it takes multiple tries with different medications until the right formula is actually developed for a specific employee. So allowing that medication go to waste, there's new protocols and rules being put into the system to help manage those costs more efficiently and effectively going forward. There's also an increased incorporation of step therapy protocols in prior authorization plans. And that's being done, the step therapy and the prior authorizations on pharmacy. But when we go back and we look at medical, some of the prior authorization practices are actually increasing behavioral and pharmacy practices going forward from an employee perspective. Many of the employers are starting to implement technology platforms that allow data to be managed across multiple vendors, and for maybe a pharmacy vendor and a medical provider to actually talk a little bit easier across technology platforms, and then additional vendors that have been hired to do that as well. We're really with the idea that they want to make changes to behavior. They're trying to improve adherences. They're trying to create a more streamlined follow-up, in some cases, of care as well. Outside of the standard medical and pharmacy benefits, because deductibles are going up higher and total out-of-pocket costs are going up higher for the employees, we're also starting to see a new reevaluation of voluntary benefits to help offset some of those costs that consumers are starting to see more and more of every single year. So the whole offering of voluntary benefits is becoming a larger topic again. We didn't see necessarily a lot of new purchases for 2017, but there's a lot more energy and movement and conversation happening in that space, and a lot more consideration for 2018 as we go forward. Outside of the standard insurance programs, there's also the whole idea of the wellness programs that are being reevaluated and redefined. Wellness strategies are being moved to well-being strategies. Some of those practices are being purchased through the insurance companies as well as through independent organizations. There's more of a target being and the focus being put on the individual as a whole entity versus necessarily just nutrition or physical activity. So that whole strategy is starting to look different, especially with the data sets that are being collected across entities. We're seeing a trend, and employers are willing to conduct more evaluations. Other health administrators and pharmacy benefit managers, overall, it was a little bit quiet for a few years where there wasn't a lot of movement in the marketplace, but we're starting to hear that people are really starting to push that conversation and really evaluate what all the options are to achieve their long-term strategic goals for the organization.
Okay, could you define voluntary benefits for us real quick before we move on to Dr. Thiele?
So voluntary benefits is a series of supplemental insurance programs. They could include critical illness, they could include accident, they could include hospital insurance, and basically it's a dollar amount that if a specific event occurs, you typically get a fixed dollar amount to help offset the cost of that single action that occurred. So if you end up, say, with a broken arm or leg and you end up in the hospital needing surgery overnight, if you had a hospital policy, because there was an incident, you ended up in the hospital, then your benefit would actually kick in, which then could be utilized to help offset the cost of your high deductible health plan. So it's a way to help supplement the other plan designs.
Okay, great. All right, well, so we're going to move on to Dr. Thiele. If you can just say a little bit about the trends that you're seeing with health plans, and then we will once our panelists finish giving some remarks, we will open it up to the questions in the chat box as well.
Great. Thanks, and thank you for asking me to participate today. As you know, I represent Caresource, and I'll start there. Caresource is a nonprofit health plan based in Dayton, Ohio. Currently, we serve over 1.2 million members in Ohio Medicaid, as well as we serve over 50,000 Ohioans in the marketplace and over 25,000 Ohioans in the MyCare product. We believe that the way to improve care is through focusing on our members' needs while working in collaboration with our state, our healthcare providers, which we call health partners, and interacting closely with the community. Relating specifically to value-based reimbursement, we currently have arrangements with large health systems, FQHCs, independent provider groups, as well as we're working with now nursing facilities, starting to work with community mental health centers, maternal health programs, and as well we're participating with the state's CTC programs. Much of our payment strategy is really based on a glide path. Not everyone or every provider is in the same place with their readiness or willingness to go with a particular type of model. So we really try to base it on what common goals we have to achieve and the readiness of our providers and ourselves to move forward with a particular type of model. We currently have several different types of VBR models, some of which include shared savings programs. We initially started off one focusing on emergency room and pharmacy costs, and we've graduated that into a total cost of care shared savings program. We have quality-based performance incentives. Typically people call those P for P, pay for performance programs. We have a risk-based capitation, per member per month management fees to support population health, as well as bundled payment structures aligning with the Ohio CPC, or previously known as the SIM project. One of the things we realized early on was just because you have a contract in place and a VBR model in place, that is not going to move this whole process forward. There's a lot that we've learned, and it's not going to happen overnight as far as how to be ready to serve in these kind of models. We need to, and we've learned that we have a considerable infrastructure to build to be able to support these types of models, and as well, our health partners, our providers, have a considerable amount of infrastructure to build alongside of adjusting to a whole new type of payment model. Things that we used to think were boring, such as attribution, now get everyone's ears perked up when we're in a room talking with providers about attribution and such. When we look at this, we're focused on how do we make this work. And some of the key areas to move forward involve establishing real partnerships with our health providers. And these partnerships have to move away from previous types of relationships we have with our providers, which really focused on contracting and credentialing and trying to get those things still to occur but not to be the focus. The real partnering we have to do and we're striving for is based on trust and common goals. And we're finding out, as I mentioned before, a whole lot of hard work. One of the key other areas that we need and we're starting to move forward with is sharing of data, bidirectional share of data, and using that data to further improvements focused on our members. We really try to focus on what's best for our members, and that's where we can align with the providers on both quality and access types of topics. It's recognized, and I'm stating the obvious, that all need to be focused on being effective stewards of the healthcare resources, which are limited today and most likely going to be more limited in the future. We do have areas of concern. There's challenges that we face. The one that sticks in my mind first and foremost is one that actually a health partner, a provider, shared with us at one point in time, and said the sun is still shining pretty brightly on the fee-for-service model. And I think this is true today, but this is changing quickly. There's an aversion of taking risk, downside risk. Developing infrastructure is a real challenge. It is expensive and actually consuming of resources and energy. Sharing of data has been a challenge, and we're moving forward on this, but there's really there's three separate kind of initiatives that all have to occur at the same time to make the data sharing work. we as the health plans have to be ready and have to be able to technologically wise to be able to share data. As well, our health information exchanges, 2 of which there are in Ohio, are going through growth to be able to share data that's meaningful and relevant with all parties involved. And lastly, and probably the most important, is a willingness to share the data. And this goes bi-directionally, having that willingness to share data, to kind of let your guard down on when you're talking about sharing information that is relevant to improving the care of people. With the recent election and such, and I'm sure we'll get into that topic here in a minute, all is being rethought and all is being challenged. But what we do believe, and what I believe personally, is that everything that we've talked about here today is still going to be relevant. It's still going to be needed to move forward. Thank you.
Thanks, Dr. Seeley. And so last but not least, Marie, if you have some thoughts you'd like to share.
I do, thanks. The consumer perspective is a different prism to look through when you're thinking about a lot of these things. As we gear up or think about what our next steps are, our greatest concerns, affordability is still right at the top of the list of our greatest concerns. The issues that I know Patty mentioned a couple of these: surprise medical bills, narrow networks, the prescription drug coverage and the tiering, and the high deductible health plans. All of those things really push consumers with respect to affordability. And overall, the biggest concern is how incredibly complex it is for consumers to understand and use their health insurance, particularly consumers who are new to health insurance or who are at lower income levels and who are not accustomed to using insurance because they have not had access to it in the past. And I mean, honestly, this is really, I'm sure all of you have this experience as well. It's not limited to people of particular education levels or income levels, the confusing nature of our insurance structure. So one of our biggest concerns is trying to address the complexity of what we're using in a way to make it understandable to people. We are focusing on a couple of different things as we move forward, particularly given the recent election. We are looking to Ohio to continue with its population health initiatives, including the CPC work that Dr. Thiele was speaking about, and the alignment of the community health improvement plans with the state health improvement plan. Both of these are really, we hope to continue to see this work moving forward at the state level. One of the other things that we're paying a lot of attention to is our effort, or the goal of maintaining Medicaid eligibility. Any conversation about a block grant for Medicaid is very troubling to consumers. It makes it very difficult for consumers to maintain any kind of level of benefits, especially when Ohio struggles economically. We see that when states struggle economically, the block grant benefits really shrink. The federal picture is a little unclear, but we'll be watching to see if CHPIO is willing to take actions to make sure that the insurance market reforms are maintained. And maintaining the insurance reforms is really pretty important. The pre-existing conditions, the upcharge for women, for premiums for women, the caps on coverage, the limited age ratings allowed, and the essential health benefits. And there's a real question about whether benefits will be cut in the time before we get whatever we're going to get in terms of replacing the Affordable Care Act. And one of the largest federal issues is going to be, for consumers, is going to be whether is the prospect of a potential repeal without a replacement. We haven't seen full plans or full ideas about what replacement would look like. It's going to take, I would suspect, some time to work that out. It's not an easy thing to tackle. but our concern really is that that's going to throw a lot of uncertainty into people's lives, and that if a repeal law is passed, that the foundation of the replace provisions is really needs to be in place as well, so people can understand what's coming down the pike. I think that the things that are really important to keep in place for consumers to maintain affordability or to change, to make happen, is really we think about what services are not subject to the deductible. So we know now that preventive services are not subject to the deductible for health insurance plans, and that's great. But if you can't get any of your lab work done because it is subject to the deductible, so it's all full price, even at a negotiated price, that's a pretty significant barrier for a lot of people. So the issue about what services are not subject to the deductible is a key issue for us in our consumer advocacy. Also rethinking how the high deductible health plans could be more value-based, because right now they, that first however much of a high, there's not any attention to value in that whole range. So for people with chronic illnesses, they really could be incentivized in a different way to maintain their care with a high value, with a plans that promoted high value care. And we also think, as I said before, that maintaining the market reforms is really important. One thing that the health insurance market could, one step that the health insurance market could take to decrease complexity and increase value is potentially to look at in the ACA marketplace. We haven't seen, I don't know that I've seen any standardized plans. I don't know if in Ohio if we have any carriers offering standardized plans, but if they are, they're few and far between, I think I can say. And the standardized plans that really make, if you're familiar with the Medicare kind of standardized plans, the A, B, C, D, all the way up to, I don't know, N, to really say, okay, these are the benefits that are covered in this plan, and the variation, and this is what you pay for them, and the variation between plans doesn't end up being the benefits or the cost. The variation is based on other things like which doctors are in the network, or what's convenient for you, or other factors related to relationships. That would go a long way to simplifying, and also could increase value and affordability. The push for value-based payments and value-based purchasing can have a really positive impact for consumers. Making it easier to get high-value care is certainly great. The concern that we have is that if you make it difficult for consumers to access needed but expensive care, then that's a problem. And some of that has to do with things like drug prescription tiering, like Patty was talking about, that the value part of that is diminished when those tiers go up in a way that the care that people need is really hard for them to get. And I was really interested to hear Dr. Thiele talk about, I think I just heard Dr. Thiele talk about this, the authorizing prescription medications for shorter periods of time. I'm sorry, Patty, if that was you, please forgive me. To say, okay, only 10 or 15 drugs at the first trial out, so that 10 or 15 doses at the first trial out, so that when you're trialing a drug, you're not providing an entire month's worth that may then not be needed. So those are some of the big things that are on consumer advocates' mind and are concerns for consumers as we move forward.
Thanks, Marie. So those of you who are on the webinar, feel free to type in the chat box if you have specific questions for our panelists, or just want to get some of their thoughts on other issues they didn't touch on. As folks are typing into the chat box, Marie, you talked about this at length. Feel free to add if you'd like. But as we think about the state and federal activities related to private health insurance, and this particularly, I think, Patty, you maybe didn't get to touch on this as much, and Dr. Teal, you did just a little bit. But which activities are you paying particular attention to, especially given the recent election and what might be happening at the federal level? And then how do you think these changes are going to impact your sector and the work that you do?
So from a large, this is Patty, from a large employer perspective, large employers are really watching right now, not necessarily the benefit mandate at this point, but they're actually watching more so from a compliance standpoint and a reporting standpoint. They're paying super attention to those types of issues because that's really what their struggle has been since the legislation was passed. So that's where their focus is really more on compliance and reporting at this point.
Any sense of whether or not the concern is whether the burden is going to be increased or decreased?
I think it's a wait and see more than anything at this point. I don't know that people are actually making a judgment if it's going to be more or less. If I had to pick one side or the other, I think that they think that the compliance issues are actually going to decrease and not increase. They'll either stay the same or they'll decrease at this point. But I think that for the most part, they're trying not to make any additional changes to systems or purchase any additional from outside vendors to support them until they really see how it's going to fall going forward.
Okay, great. And Dr. Teal, what are your thoughts on that as well? And so Patty's kind of describing that things are at a bit of a standstill right now. Is that how you feel coming from a health plan perspective?
Well, things are at a moment at a standstill, but I don't think they're going to be standing still very long. So that's at least my impression. You know, we've been, and I'm sure everyone is looking at, okay, what are the possibilities? What could happen? You know, what are the impact of that? You know, one of I feel is likely is that there's one way or another, there's probably less dollars coming down from the federal system trickling down, be it, you know, block grants, be it through PMPM capitation. Those are likely to come down, and some of these things could be fairly quick. You know, the new administration could take some pretty quick actions. You know, things like not enforcing the individual mandate or undoing some of the risk adjustment rules and regulations. Then you have following that, in next year, you know, Congress could repeal some legislation which dries up some of the revenue which flows into the system. So there's a lot that could happen pretty quickly with you know, Vice President-elect Pence in there and the Indiana kind of model that they represent. It, you know, these reliance on federal waivers and more creative ways for states to manage in a restricted funding environment, I think, are going to be very real. You know, and so I think we're going to see more and more of those type of activities coming forward. So I think, you know, I don't think I mean, everyone wondered what's going to change, what's not. I don't think anybody really knows. I think what everyone does know is that things will change. But kind of our thought is that things are not going to go away. It's just going to be very different in a different environment.
Thanks, Dr. Teely. So I'm going to move to a question that's in the chat box that I think is directed to Patty. Patty, it was when we were talking about the targeted messaging for chronic conditions. And the question's around what the trend is with rolling out these messaging initiatives.
So what I've seen our employers do, they've done it multiple different ways at this point in time. If they're working with their third-party administrators, some of the programs actually starting immediately at the time of open enrollment. And then others are actually on a tiered basis based on certain claims data, that as certain claims trigger a system that would then say this person needs to be targeted for these types of communications. Others are doing an annual review, usually I want to say in April or May, of how they performed over the last 12 months. And from that data, then they start targeting individuals with specific disease categories and or that have a potential to have specific disease categories on a longer term basis.
Thanks, Patty. So we have another question really kind of around the issue of accountability. And you know, another way that we've heard this phrase is personal responsibility. So what are your thoughts? You know, I'll open it up to all of you on how to hold people accountable for their behavior and what that might look like going forward. No takers?
No, I'm thinking that's a challenging area, obviously, because it's a dramatic pause you just heard. It's a challenging area, and we've worked a lot on trying to incentivize our members to do the right kind of actions moving forward. Be it, you know, usually it's around a quality type of initiative, or making sure they're getting, you know, their adolescent well child visits, things like that. And we incentivize the providers as well. It's a challenge with individuals to move them, and I think this is something where I don't know that there's a perfect solution that's out there right now. You know, people always say that, you know, using a stick is more effective than a carrot, but no one really wants to go down that pathway, especially when a consumer or a member is involved. When I think of the type of collaborations which value-based type of reimbursement models have, you know, in a perfect world, you would then have a much higher likelihood of members, or we call them members, providers call them patients, actually moving forward with a proper type of care, because they're hearing the same messages, they're getting incentivized, they're getting encouragement from trusted advisors, you know, their healthcare providers, to move forward. So I think with that alignment, we'll get better, you know, member adoption of, you know, kind of what we all consider to be the right things to do. But it is a challenge. I don't think there's a simple solution to that.
This is Marie. I think one of the things that understand is that the relationships that patients have with their care providers makes a big difference in terms of their motivation, maybe to respond to care provider, whether it's a doctor or a nurse practitioner or a community health worker or a care coordinator, to be responsive in terms of some of these really, you know, these habits that are intractable, or addictions. You know, when we think about smoking or we think about sugar, but to try to put in place a kind of a regimen or a habit change is not an easy thing, and the relationships that people have seems to be one factor that helps. So to the extent that with our comprehensive primary care model, we can, you know, value the relationships that can be built around these particular behaviors, so that it's not all falling on the physician, that they really have a team in place to help them with motivationally, you know, motivationally encouraging their patients, and getting paid for that service, getting paid for care coordination, or having that be part of the, you know, feel like that's a valued part of the payment, I think could potentially help make some progress in this area.
Patty, and I think I want to add to what has been commented on already, which I agree with and support. I've actually been involved in a few different programs over the years where they were around behavioral changes, and two of the things I would like to note about it is that the first one is that as you try to implement it, typically it takes the consumer or the patient or the employee almost a life-changing event to occur. It doesn't have to be a bad event, but the individuals typically who have had the most success in those programs, something opened their eyes that was personal and spoke to them about it. It wasn't a language. It wasn't us talking at them to say, you're a bad person and you need to change your behavior, or you're not doing the right things to keep costs down. That never came up in those conversations. It was typically, you know, I was with my grandchildren this weekend and I wasn't able to keep up with them. Or I was invited to go for a walk through the park and I could only do a quarter of the walk while my friends were all able to do the full mile. So it's typically something like that that's going to actually help drive a behavioral change. And then I think it's also very important that we're cognitive of, as providers and other experts in that area are trying to provide support, we're automatically assuming that the person that we're talking to, that topic's actually top of mind to them that day. And I recently saw actually a fairly strong presentation of, here's a doctor talking about blood pressure and cholesterol and your wellness checks, and the patient sitting there going, wait a second, my kid's at home with a fever. I have a mom who's now living with me with Alzheimer's, and I'm on probation now at work because I haven't been able to make it to work on time yet, because every time I'm supposed to go to work, something happens with the kids or with my mother, so I'm not on time. That's top of mind while we're trying to actually talk about health issues. So we really have to be cognizant to meet the individuals where they're actually at.
Thank you to all of you. So I want to end with, or we're almost out of time, but I kind of want to take that a different route. So we have the health behaviors, but then Marie, you talked about this, and Patty, I think you highlighted this as well, around the complexity of using health insurance and just the complexity of navigating the healthcare system. And Patty, you talked about the use of cost transparency tools for employees. So to what extent, and Dr. Chilius, you can weigh in on this as well, to what extent do you see transparency tools either impacting consumer behavior or having a positive effect on either cost or quality that's provided in the healthcare system?
So I would say from an impact standpoint, I think it's developing a level of awareness. I think part of it has to do with where the consumer is entering into the delivery system as to how strong of an impact the transparency tools are having. I think some areas probably a little bit more than others, but overall I would say it has a lower uptake. Educated the individual is, then I've seen them start to be utilized. I would not say that they're necessarily utilized at a very high percentage today.
This is Craig. One thing to add, and I'm speaking just an opinion. I don't have any data behind this, but the one thing I wonder when we do that, and I've heard some anecdotal things, is that it may be an unintended consequence, and it, the consumers may, even if they don't have a high adoption rate, the fact that it's posted out there, it brings transparency to the cost, and that drives some pressure back to, if two different particular providers or hospital systems provide the same service and the same quality level, and the costs are significantly different, it creates some pressure to really to reconcile that difference, to bring that difference, to make it go away. So that's something to consider as these things. Transparency is a powerful tool, even in somewhat of an indirect kind of a use.
The transparency from a consumer perspective is pretty important, but I think that one of the things that's important for people to remember that there's not very much health services that are shoppable for people. So they're really, their realm of possibility is smaller than the range for which we would like to have transparency. And it's precisely for the reason that Dr. Seeley said, is that transparency does create its own pressure on cost and value that consumers then benefit from.
All right, well, thank you all. And thank you particularly to our panelists for such a really insightful discussion, and to all of you for your engagement throughout this. We will be posting the webinar on our private health insurance webinar page on the website. And so if you're interested in hearing this webinar or pieces of it, or forwarding that information to your colleagues, you can access that on our website. And I just wanted to let you all know of an upcoming forum for that we are hosting next week around the state health assessment and state health improvement plan. And so if you have not registered for that forum, please go ahead and do so if you are interested. The time frame is, I think it's closing out soon. So if you're interested, do it now. And then also we have a survey that has been typed into the chat box. If you could please take this survey to help inform our future webinars, we would very much appreciate it. Thank you all and have a wonderful day.